Today's video, we're going to focus on gastroparesis, but before we can start talking about this condition, we need to briefly go over the different layers of the GI tract and how the movements of the GI tract are controlled and coordinated. So there are 4 foundational layers of the GI tract, starting furthest from the lumen. So we first have the serosa, and this is really just an outer sheath of epithelial cells and connective tissues to hold everything together. Next is the muscularis externa, and the muscularis externa is made up of a longitudinal and a circular smooth muscle layer, and sandwiched between these is the myenteric plexus, which is the first level of the enteric nervous system that we're going to talk about, and this primarily controls peristalsis. So the next foundational layer is the submucosa, and the submucosa is another layer of connective tissue and blood and lymph vessels. But the submucosa also contains the second level of the enteric nervous system, being Meissner's plexus, and this will primarily control GI secretions. So the last layer that we've talked a decent amount about in other videos is the mucosa, which contains all of those specialized epithelial cells. So now let's talk about control of the GI tract. So coming down the nervous system tree, we have the central nervous system and the peripheral nervous system. And in the PNS, one of the main branches is the autonomic nervous system, and which, as its name implies, just happens and we don't have to think about it. So in the autonomic nervous system, there are 3 branches. We have the sympathetic nervous system, which, if you remember, controls that fight or flight response. The parasympathetic nervous system, which controls the rest and digest response. And the enteric nervous system, which controls the GI tract and can do this either on its own, or it can receive input from both the sympathetic and the parasympathetic nervous systems. So input from the sympathetic nervous system comes from preganglionic cholinergic neurons, which will release acetylcholine to act upon the nicotinic receptors of adrenergic neurons, which will ultimately stimulate the release of norepinephrine into the synapse to signal to the enteric nervous system, and this will lead to reduced GI motility, because think fight or flight, and your blood flow will need to be deviated from your GI tract to ensure appropriate blood flow to the regions that need it for that fight or flight response. Like if you need to run away, for example, it can be shuttled to the periphery. So input from the parasympathetic nervous system also comes from preganglionic cholinergic neurons, where again acetylcholine is going to be released to act upon nicotinic receptors, but now it's going to be acting upon other cholinergic neurons to lead to acetylcholine release into the synapse to then signal to the enteric nervous system to proceed with digestion. So it will promote GI motility, and it will promote secretions, kind of like what we talked about with cholinergic toxicity with pesticides, but obviously this is a more normal cholinergic signaling response. So I do want to mention that in this control network, there are 2 other important neurotransmitters involved in enteric nervous system control, and that is dopamine, that's going to be released from dopaminergic neurons, and this will similarly lead to reduced GI motility, just like norepinephrine. And the second neurotransmitter will be serotonin. And serotonin will be released from serotonergic neurons that will lead to the promotion of secretions and motility, just like with acetylcholine. So this is the brief boot camp I wanted to provide on the enteric nervous system, but this is a very simplified version. But for our discussion today about gastroparesis, this should be sufficient. So normally this intricate complex signaling network ensures the proper timing and coordination of digestion, secretion, motility, and absorption throughout the GI tract. But if there are any impairments in this signaling network, these functions are not properly timed and coordinated. So this can lead to delayed gastric emptying time, for example, since we're discussing gastroparesis. So what delayed gastric emptying time means is that the movement of stomach contents into the small intestines is either delayed or stopped altogether. And this leads to that typical set of symptoms that our patient is presenting with. So moving to the next slide. Now, gastroparesis can be from a number of causes, but today we're really going to focus on diabetic gastroparesis or drug-induced or exacerbated gastroparesis. So diabetic gastroparesis is a potential complication of, as you would guess, poorly controlled diabetes. So chronic hyperglycemia can cause neuronal damage and eventually can lead to autonomic and enteric neuropathy, resulting in the sort of dysfunctional neurotransmission, a reduced number of contractions in the GI tract, and a lack of coordinated contractions. And this results in that delayed movement of contents from the stomach into the small intestines. As a side note, hyperglycemia on its own can actually lead to delayed gastric emptying time, but if you can achieve proper blood glucose control, this delay is reversible, whereas the delay with actual gastroparesis from that autonomic and enteric neuropathy will not be reversible. But if you can get this blood glucose under control, you may be able to relieve some of the symptoms or make them less severe. So moving to the next slide. So now, if the delayed gastric emptying in diabetic gastroparesis is irreversible, how do we treat this condition? So in the setting of diabetes, achieving and maintaining that glucose control is crucial, just like I said on the previous slide, to ensure the hyperglycemia itself isn't affecting gastric emptying and to prevent any neuropathy progression. More broad recommendations for gastroparesis that will work for diabetic gastroparesis and idiopathic gastroparesis would be to include a lot of lifestyle modifications, which I won't get into detail here. There's also going to be some symptomatic treatment for the nausea and vomiting that's associated with gastroparesis in the form of antiemetics. But again, these are just a band-aid, but they are usually needed. But today the focus will be on a few prokinetic agents indicated for the treatment of diabetic and some other causes of gastroparesis. So if we move to the next slide. So let's start with metoclopramide. So remember, serotonin promotes motility and dopamine inhibits motility. So metoclopramide is a serotonin 4 receptor agonist. And it's also a dopamine D2 receptor antagonist. So at the 5-HT4 receptors within the enteric nervous system, metoclopramide will bind and activate these receptors, triggering motility and secretions. And then at D2 receptors in the enteric nervous system, metoclopramide will bind and inhibit these receptors so that dopamine cannot bind and activate it to trigger the inhibitory effects on motility. The inputs of both of these effects leads to increased resting esophageal sphincter tone, improved gastric tone and peristalsis, a relaxed pyloric sphincter, and an augmented duodenal peristalsis. So the combined effect of metoclopramide on the GI tract leads to increased gastric emptying and a decrease in the transit time through the small intestines. So while this is generally the agent most people think of when it comes to treating gastroparesis, there is a primary concern with this agent. So metoclopramide is a dopamine receptor antagonist, which can lead to extrapyramidal symptoms, or EPS, and this is also known as drug-induced movement disorders because dopamine is so important for movement. And by inhibiting dopamine signaling at sites outside of the GI tract, this can acutely present as a dystonia, which is an unintentional sustained muscle contraction, or akathisia, which is restlessness. But long term, this can actually present as Parkinsonianism or tardive dyskinesia. And there is actually a black box warning for tardive dyskinesia, which involves involuntary repetitive body movements that can be irreversible. So because of these reasons, treatment should not exceed 12 weeks. The next agent we're going to discuss is erythromycin. And you may be confused because this is an antibiotic, right? Well, erythromycin also acts as a motilin receptor agonist as well. And motilin receptors are found in the enteric nervous system and possibly on the smooth muscle cells of the GI tract as well. And when bound by either motilin, which is released by cells in the small intestines, or erythromycin, this leads to GI contractions and increased GI motility. Unfortunately, because of motilin receptor downregulation, the effects are very short-lived with erythromycin, and tolerance appears after several weeks. So this is an option for sort of periodic use, potentially during a drug holiday with the metoclopramide after you hit that 12-week max treatment, for example. So moving to the next slide. Now there are two other agents you may come across as you're researching that were actually withdrawn from the market. And these are cisapride, which is only a serotonin 4 receptor agonist, and domperidone, which is a peripherally selective dopamine D2 receptor antagonist. So there is a less risk for extrapyramidal symptoms. So both of these agents were removed from market due to the risk of them prolonging the QT interval, which significantly increases your risk of arrhythmia, and specifically one unique arrhythmia known as torsades de pointes, which you may see abbreviated like this. And you'll come across this quite a bit as either a black box warning or a severe adverse drug reaction for a number of drugs. And what it is it's a unique form of ventricular tachycardia that sort of looks like the QRS complex is oscillating around the isoelectric point or the baseline of the ECG. So now talking about side effects for a second. So you will see QT prolongation a lot as a potential side effect, but not all QT prolonging drugs carry this sort of similar risk of arrhythmia. So the more a drug prolongs the QT interval, the more likely to trigger an arrhythmia or torsades. For example, erythromycin at low doses that's used for gastroparesis prolongs the QT interval by only about half as long as cisapride. So alone, erythromycin has some risk, but if you go ahead and combine it with other QT prolonging drugs, or give it to someone who has a predisposition for an arrhythmia, that is when there can be this concern. So this is why you should be looking for drugs that have QT prolongation as a concern and start categorizing them based on their risk or their degree of QT prolongation. So you have a better idea of which drugs will be appropriate versus inappropriate with certain patients. Now this wraps up the treatments of gastroparesis, but provides a great segue into drug-induced or exacerbated gastroparesis, since we are talking about adverse drug reactions. So moving to the next slide. So as you can imagine, based on all the receptors and the neurotransmitters involved in controlling gut motility, there are a lot of agents that can lead to delayed gastric emptying time. So starting off with the most straightforward being the anticholinergics. Because any agent that's going to inhibit acetylcholine binding at the cholinergic receptors in the GI tract will lead to this reduced gut motility. And this will include things like constipation and delayed gastric emptying time. So this can be a wide variety of agents, so I won't get into the full list, but if you actually look up anticholinergic medications, you'll notice that the list includes a lot of drugs that target other receptors, but they have off-target anticholinergic effects, like antipsychotics, histamine 1 receptor antagonists like diphenhydramine or Benadryl, antidepressants, and the list goes on. So the next agents we'll talk about will be the adrenergic agonists. And these will activate the same receptors as the norepinephrine released by adrenergic neurons and ultimately lead to reduced gut motility. And this will again be any agent that will activate alpha or beta receptors. And the one I normally think of is clonidine, which is a centrally acting alpha-2 receptor agonist for resistant hypertension. But there are a number of others. Similarly, dopaminergic agents or dopamine receptor agonists, which are used in the treatment of Parkinson's, can similarly stimulate those D2 receptors in the enteric nervous system to, again, reduce GI motility. So opioids are our next set of agents, and they are notorious for slowing down GI motility. And they are agonists at opioid receptors, particularly the mu opioid receptors. And their activity at the mu opioid receptor is what is responsible for the analgesia effect of these agents. But unfortunately, these receptors are also found throughout the enteric nervous system. And opioids trigger an inhibitory effect through reduced acetylcholine release, leading to, again, that reduced GI motility. So the last agents we'll talk about are a little bit different. So first are the GLP-1 receptor agonists. And these are commonly used for type 2 diabetics. And these mimic endogenous GLP-1 that's usually secreted from the intestines following feeding to stimulate insulin release. Now, GLP-1 and these agents also centrally signal to delay gastric emptying time. And this helps to promote satiety and potentially weight loss for type 2 diabetics, which is good, but not if they have diabetic gastroparesis, because then you're worsening it with these agents. So pramlintide works similarly, but as an amylin analog, where amylin is usually released with insulin and will promote satiety and weight loss, but again, it does this via delayed gastric emptying. So moving to the next slide. So it will be important that when a diabetic presents with gastroparesis symptoms but is on one of these agents, trialing a withdrawal period will be important to determine if it is truly gastroparesis or just a side effect of one of their treatments. And a similar strategy can be applied for other patients with gastroparesis symptoms on these other agents if the risks outweigh the benefits. So just to summarize, there are very few treatments for gastroparesis, basically just metoclopramide and erythromycin, along with some antiemetics for symptomatic support and proper glycemic control if applicable. However, there are many more agents that can potentially worsen or cause gastroparesis-like symptoms, so it's important to look for these when a patient presents with these typical symptoms. Also, slightly unrelated to gastroparesis, but start looking for QT prolongation as a side effect when researching medications and begin placing them into bins based on QT prolonging extent and the risk of torsades.